Good afternoon to you in Barcelona, and hello to all of you that are joining us remotely. I'm Dr. David Levine. I am the Group Senior Vice President of Advanced Analytics and Data Science at Vizient. I'll go over a tiny bit of what Vizient does, but in general, it's the largest performance improvement company that's owned by the majority of medical centers across the United States, and we drive performance improvement for our member hospitals. This is a plenary session focusing on harnessing big data, which is a central tenet of the work of the IHF's Special Interest Group of the same name, which is sponsored with IHF by Vizient. Today we're going to explore how many terabytes of data does it take to make a decision, and we're going to hit on, with two other presenters besides myself, from storage of data to driving insight of data for change, and touching on using AI and machine learning in that data venture. So with that, can we have the slides come up? Okay, perfect. Great. Now we have had our one technical glitch, so we are safe for the rest of the session. Vizient's mission is to strengthen members' delivery of high-value care by aligning cost, quality, and market performance. So it's really getting in the U.S. at value, because we know that sometimes the least costly care is not the highest quality of care. You want that balance, though, where one is not just spending for the most expensive items and not getting better health outcomes either. So it's really that balance. Vizient connects the nation's top providers. We serve more than half the healthcare organizations across the United States, and that includes 97% of the academic medical centers across the United States. So you think Johns Hopkins, you think all the university hospitals across the U.S., Stanford, are examples of the academic medical centers that we serve. We also serve more than 50% of acute care hospitals throughout the U.S., and that really goes from critical care, very small hospitals, to community hospitals, to those large integrated health delivery networks, such as Intermountain as an example. We also serve greater than 20% of the ambulatory market in the U.S. That seems small, but if you know anything about U.S. healthcare, the ambulatory market is so fragmented, and so that's actually a significant chunk of the ambulatory market. For a scope of the data that we deal with, we have over $165 billion worth of supply spend data, over 31 million inpatient encounters that are sent directly from our hospitals in the U.S. to Vizient, millions of patient records, 450 million outpatient records. Additionally to supplying the data and analytics, we're sort of an end-to-end performance improvement organization. So we provide consulting, the expertise. We're rated as the 5th largest healthcare consulting firm in the U.S. By Modern Healthcare. We have over 365 consultants working for the company, many of them clinicians or people that have worked and operated in hospitals across the U.S. And we have, because of our great penetration in being the largest group purchasing organization in the U.S., we have over 190 sourcing experts to help manage supplies. Additionally, besides the consulting, and I think one of the most attractive things about Vizient is the peer collaboration, and we really bring our hospitals together. And as competitive as the market is in the U.S., when it comes to quality, our member hospitals will work together to really improve the care across the nation. So they get together on how to decrease hospital-acquired infections, how to optimize length of stay versus readmissions, and spend a number of initiatives bringing our members together around improvement that's based on data. We have 4 areas of focus: strategic growth, where to increase one's footprint, where to add into the outpatient setting, and in certain cases, when to stop adding and building and when to concentrate on core services to be successful. Spend a lot of time, and most of the data I'll talk about today is around operations and quality, and how do we optimize that to make the best patient experience with the best patient outcomes. As I said, we're the largest group purchasing organization, so we spend a lot of time helping supply chain optimization of getting things at the best contracted price and making sure that there's supply resiliency when things like pandemics like this come up. And then we spend a lot of time with the pharmaceutical part of the supply equation as well, as far as acquisition and contracting of supplies. But then where I think the sweet spot is variation of care around pharmaceuticals and when to use those pharmaceuticals and when not to. Don Berwick, who was the president of the Institute for Healthcare Improvement and also had worked for the Centers for Medicare and Medicaid in the U.S., noted just last year, the biggest issue facing the American healthcare system is our inability to improve. I see a loss in the focus on quality. And we've gone, in my medical practice, I'm an emergency medicine doc. I ran one of the busiest emergency departments in the United States before coming over to the Vizient family, and still practice some emergency medicine, not there anymore. But went in my career from no data, or a real paucity of data, hardly any data, to a sea of data. But yet we've not seen, with the amount of data that's come through, we haven't seen the improvement in healthcare that we would have thought or liked to have seen with the data that we've driven. And that's because the data alone doesn't give you improvement. It's a key component, but you need data plus change to get improvement. An improvement being the systematic measurement and evaluation of predetermined outcomes of a process and the subsequent use of information to change the process based on expectations of the customer. And that's a quote from Donna Badium, who's one of the leaders in healthcare improvement. So generally, we get to data, we've focused a lot on analytics and technology, and we get information. And then people have stopped there in a lot of cases and not got to the context, the insight, the change. And there's been focus on how many zillion metrics can you put on a dashboard. But what really are those meaningful actions that you need to take off some of those metrics on a dashboard to drive change? Shannon Sims, who you're going to get to meet, he's going to actually moderate our question and answer session remotely. Shannon Sims is my senior vice president of analytic operations, and he's MD, PhD. He took the Kubler-Ross stages of denial or grief and apply them to data. From there's not a problem, the data's completely wrong, need different metrics, my patients are sicker, okay, finally, maybe we can do better. It's one of my favorite things when I go visit our hospitals and our clinicians and sort of taking them through of where are you in that journey. And so the data scientist was thought of being the next piece to piece this all together. And I think that's partly true, because an ideal data scientist, in my mind, I don't know that's the sexiest job of the 21st century, as Time Magazine had labeled it, but the ideal data scientist can actually not so much do the programming in Python and do but really coming up with the meaningful insights out of that data and connecting that with best practices to drive change and getting the right people together to bring it together. Some key things that you need in the data, and this is an example of an output of our clinical database that large group of our membership uses. Not so much that I want to focus on our database, but I want to focus on the key ways that make data usable for clinicians. One of the big ones is the competitors and the custom competitors that are transparent, that you can actually see by name who you're getting compared to. Commonly, when I was working at this busy emergency department, they'd say, hey, Dr. Levine, your doctor's slow. And I'd say, I'm Dr. Good Quality, and I'm taking care of sicker patients, if you go back to the stages of denial. What would more meaningful is when they said, hey, when I compare you to your peers that are seeing the same kind of patients, either at my institution or at institutions that are like mine, that helps to drive change. And especially if you think, at least in the U.S. healthcare system, where there's only a certain number of places where people train, and you like to be compared to where you've trained or where your peers have gone, where there's similar patient acuity. That's incredibly important. And so in our database, we have all the U.S. News and World Report top performers. We have all the academic medical centers, but we also have a broad base of other competitors that you can compare like to like, and that transparency is key to be able to really, and then the ability to drill down. So when I see my data, I can understand what patients are causing that metric to not look good. And we can have a conversation about them. Is it one or two patients, and are they an outlier? Is there an opportunity to improve that care, or is it a more pervasive issue? As I said earlier, and then it's the ability to talk about one's performance and network and collaborate with one's peers to find out what they're doing to improve around length of stay issues around a certain service line or hospital-acquired conditions or whatnot. And then the data that one holds a doctor accountable to, you have your hospital metrics, which are key, but they have to speak to some of the national mandated metrics that the hospital is forced to report as well. And so that's the key of the data, is making it useful, tangible, meaningful, where you can drive change. And then it's not only the data itself, it's the methodologies that go under it that are transparent. So this is an example of one of our risk models for spinal fusion, a subset of spinal fusion patients. And when the doctor can see that their expected value is, they'll say, hey, my patient's really sick. You can run the risk model, and you can actually show them all the different factors and which ones of that patient got picked up or not. And there's not a secret code. They're all tangible comorbidities or patient characteristics that go with it. There's a lot of times when there's risk adjustment that's out there that's statistically good, but if it doesn't have something that's actionable, then it's not nearly as helpful. Scorecarding and sort of seeing again how you are against your peers is really an important way to drive change. And actually, we've developed something called the Quality and Accountability Ranking that comes out annually for our members. It's with current data. The rankings just came out a few weeks ago for this year that ran from July 1 of last year through June 30th of this year, looking at different domains from safety, mortality, effectiveness, patient-centeredness, efficiency, and equity. And one of the keys is you can drill down to the service lines that are causing you issues, and then you can get down to the exact patient level and the case level. And this, for our academic medical centers and now for our community hospitals, has been one of the biggest drivers of change, is to see tangibly and risk-adjusted, normalized data comparisons where one compares against one's peers. And then actually we bring top performers together to talk about what they've done to be top performers that people can learn. And we've seen year over year now improvement around some of our key metrics. And then, as I said, you can drill down into the type of data, and you can look at it by a specific service line. You can look at it from a resource utilization piece of things. You can slice and dice the data down to almost any granularity, and that's what's key. So ultimately, to get to that value equation, you need to look at your resource utilization from how are you doing overall in quality, how are you doing on that service line, and a service line that you might have an issue around cost, then what's driving the cost? Are you using more expensive supplies than others but not getting the same outcome? Are you not getting the right and best contracted price? You're not using things on contract? Are you wasting a lot of supplies that you're opening in the OR that can't be used? And that's the way to take the data and drill down. And that's where you take data, and as Vizient, our role is an accelerator to help that change, to bring people together for us to surface from that data insights that actually drive that change to make one get better. This is just an example. I'm not going to read this off to you, but like number of different collaborative projects that we've done this year. Generally, there's at least 30 up to 100 members that are on these collaborative projects. We do them remotely, obviously with COVID, and we'll probably continue doing a lot of them remotely moving forward. Just looking at different things in different areas, from reliability to systems of care to workforce as examples. And that's the end of my formal talk. I would like to now introduce Professor Anupam Sibal, who is the Group Medical Director and Senior Pediatric Gastroenterologist and Hepatologist at Apollo Hospital Group in India. He actually is seated right here, so he will do live Q&A, but we weren't sure that thankfully he was able to come here in person, but we're going to play the video he pre-recorded for this session. So with that, I'll let you roll the tape for Professor Sibal.
Greetings from New Delhi, India. And now that handshakes and hugs are out, I begin with the traditional Indian greeting of Namaste, which means Let the divine in me bow to the divine in you. I'd like to thank the organizers for this opportunity to talk about the importance of data in making decisions. Medicine is becoming increasingly complex. There are now 13,600 diagnoses, 6,000 procedures, 4,000 surgeries, and every week we add on to this already very large list. Knowledge is exploding. If you go on to PubMed, where peer-reviewed papers are published, and you type cardiac disease, you get 1.3 million papers. Type diabetes, and 838,000 plus papers. And surprise, surprise, if you type Friday the 13th and medical issues, you get 12 papers. Now let's look at what has happened with COVID and the knowledge explosion. Type COVID on PubMed and we get 210,000 papers. COVID and medication, 26,000 plus papers. Vaccination, 27,000 papers. COVID in children, 56,000 papers. We are on day 600 plus of the pandemic. And if we look at the number of papers that are published, it works out to more than 300 per day. And that works out to roughly 13 papers per hour. So by the time this session finishes, we'd have 6 or 7 papers to go through just on COVID. And because of the pace at which knowledge is increasing, it's very hard to keep abreast. And the gentleman here says, I'm worried that 20% that changes is the only 20% he knows. Daniel Macy's 20 years ago had said that current practice depends upon the clinical decision-making capacity and reliability of autonomous individuals practicing for class problems that routinely exceed the boundaries of unaided human cognition. This, as everyone acknowledges, is a reality today. The complexity keeps getting more and more complex. And we are struggling. And that is because it takes 50 years to get a wrong idea out of medicine and 100 years to get a right one into medicine. Technology is everywhere. We just need to look out. Everywhere, wherever our eyes go, we see the benefits of technology. COVID drove home this point very strongly. Arogya Setu, the app that the government of India established for tracking of COVID, became the most downloaded app in 13 days, 50 million downloads. We at Apollo developed an AI-powered self-assessment risk tool for COVID, and we had over 16 million downloads. Before I talk about some of the work that we've done in this space, I'd just like to give a brief overview of what we do. We are an integrated healthcare enterprise. We have hospitals that we own and manage. We have a network of birthing centers called Cradle. We have a network of 150 primary care clinics. We have daycare centers called Spectra. We have a robust home care service. We have a network of dental clinics, an expanding diagnostic service line, more than 3,900 pharmacies, a network of clinics catering only to individuals with diabetes. Medvasti is our internet-based learning platform. We have MedSkills to upskill healthcare professionals. Apollo 24/7 looks at virtual consults and providing medicines at the doorstep and providing a host of virtual facilities. Apollo Life looks at wellness. We have a global projects division that looks at consulting services globally, and Apollo Hospital and Education and Research Foundation oversees education and research. And we have 2 medical schools and have more than 900 postgraduate trainees in 43 specialties and super specialties. So when we started looking at big data, we started looking at AI and ML, we looked at 9 concepts. Ideation, it's extremely important to realize what is the clinical problem where AI, big data would be useful. Look at data management, load the data after you identified it using the IT team. And at every step, we had clinicians very actively involved. Analysis and modeling, extremely crucial. All this has to be within a regulatory and ethical framework. So the ethics committee is involved. Validation is crucial, and this means validation internally, validation externally, locally, nationally, internationally. Presentations, and finally publications, developing the API, integrating it with our EMR and the Apollo 24/7 software. developing a network, and this network again would be local, regional, national, international, and then availability on commercial platforms. And we've been using the Azure marketplace. And of course, it is crucial that we review and re-review. So some of the work that we've done based on big data analysis. So I'll just give you a glimpse. The AI cardiovascular risk score, we looked at 400,000 health checks, 600,000 discharges of individuals with cardiovascular disease. We developed a model looking at 32,000 records. We validated this in 3,200 individuals, and then we've run a prospective study involving 33,000 individuals. And the idea really is to predict what is the risk of developing cardiovascular disease in 10 years. For asthma, we looked at acute exacerbation and the risk of developing an acute exacerbation in 90 days. Now, we know that liver fibrosis is significant, especially with non-alcoholic steatohepatitis becoming very important. And typically, we either have to use an elastograph, it's an expensive machine, or do a liver biopsy. So we've been developing an algorithm that can predict whether there is fibrosis without using an elastogram or doing a biopsy. We know the concerns that are with antibiotic resistance, so we've developed an empirical antibiotic recommendation by looking at more than 100,000 isolates, and I'm going to talk about this. So you can see the size varies. It's about 800,000 for asthma, 25,000 for liver fibrosis. COVID risk scanner, this has had major uptake with more than 16 million downloads. COVID mortality, and India went through a very difficult second wave. And when we went through it in April and May, there was a lot of pressure on the health system. But I have to say that our mortality figures per million population were the lowest, less than 300, whereas for the other 4 countries that had the highest number of mortalities, it was upwards of 1,500 per million. Here we have a risk predictor of death at 7 days or 28 days. Heart failure, the risk of developing heart failure, 5 years. Breast cancer, the risk of developing breast cancer at 5 years. Stroke risk stratification, the risk of developing stroke at 10 years. And cardiorenal complications in diabetes, again at 5 and 10 years. So a variety of different organ systems involved. And the idea really is to be able to use data effectively and to be able to make interventions and make interventions at the right time. For fibrosis, we looked at 25,000 plus records and identified who fits into mild risk, moderate risk, high risk, and what is it that we need to make a difference. But sometimes we don't have big data sets like 25,000. Acute liver failure, and I'm a pediatric gastroenterologist. This is an area of interest for me. So we looked at 100 children. This is an uncommon condition, but can be fatal without a liver transplant. So we looked at 100 case records. We looked at the enzymes, we look at INR, encephalopathy, and so on, and we're able to develop a predictive model. And while we can argue that you need very large data sets, but even with small data sets, you can make a difference. And in this paper published in Harvard Business Review, they talked about how small data can play a big role in AI. We have tiny AI, and we have the ability now to develop deep neural networks with small data. And I think that really opens up new opportunities when the data set is small. Turning to our work with cardiovascular disease, so there is a clear user manual that goes out. We predict minimal risk, moderate risk, high risk, different scores. We give out a risk score report to the family, to the patient, and to the caregiver with what intervention needs to be done at what stage. And we've broken it down to individual steps. So when a patient comes in, what happens at registration? Who does the review? What is the role of the physician, nurse, health worker? What sort of equipment is needed? What all is done? And we also time it in terms of how many minutes will it take to be able to do that intervention. So we've tried to break this out really on how it functions on the ground. So we ran series of meetings, some of them virtual, some of them physical, pan-India, across our system, outside our system, to get a buy-in. Turning to antimicrobial prescription. So we looked at 20 locations, age group of patients from 0 to 90 years. We looked at more than 100,000 isolates. There were 57 different types of specimens, 180 microorganisms were identified, and 141 antibiotics had been used against these 180 organisms. So we applied the algorithms, did all the mathematical analysis. We looked at different specimens, what would happen with blood culture, urine culture, stool culture. We looked at samples from different locations. You know, these are all the metros: Delhi, Bangalore, Hyderabad, Chennai, Kolkata. And the idea really was that if an individual presents to any of our facilities from a particular area with a particular sort of infection, based on the information that we have and the analysis that we would have done, we would be able to arrive at an impression on what is it that this individual is suffering from in terms of the bug, and what is the likely sensitivity pattern. So instead of shooting in the dark, which is what we do till we get a culture report, we can actually predict what antibiotic is going to work, and that's going to save us time, resources, money, and also prevent antimicrobial resistance. So we're very excited about this project, and we are expanding the scope. COVID mortality, you know, here we have green, those who survived, and mortality, and this is when we had the peak. So we looked at different parameters. We looked at INR, we looked at BMIs, we looked at clinical presentation, we looked at lymphocyte counts. We then looked at positive predictive value, negative predictive value. We looked at all the accuracy parameters, and then finally arrived at the score of 21 parameters, 7-day mortality and 28-day mortality prediction, which was then subsequently published in scientific reports published by Nature. For the younger generation, using technology comes naturally. In fact, it comes to them at a very young age. But for some of us, adoption of technology can be daunting. But I think the time has now come for all of us to take that leap, because only then will we be able to reach out to our patients and provide the best care to them. And let's face it, providing the best care and having happy patients is what excites us every morning when we get ready for work. Thank you very much for this opportunity.
Thank you, Dr. Sybil. What a great presentation. Now I'd like to introduce via video Professor James Teo. He is the Clinical Director for Data and AI and a Professor of Neurology at King's College Hospital, NHS Foundation Trust in the United Kingdom. I'll turn over the video to Professor James Teo.
Hello, I'm Dr. James Teo. I'm a professor of neurology at King's College London. I also work at King's College Hospital, NHS Foundation Trust, and Guy's and St Thomas's and NHS Foundation Trust in London. This evening, we'll be talking about data, health data, and how many terabytes of data a hospital uses in handling healthcare. Before we proceed, these are my declaration of interest. I receive a significant amount of research funding from a number of government agencies, as well as medical device research support from the following agencies. I'm also a developer of natural language processing AI. So since February and March 2020, we've seen a huge explosion in the amount of medical data available, largely focused around COVID, but exploding throughout the healthcare ecosystem. The amount of health data keeps expanding, and we are in the process of drowning in the volume of data. Terabytes doesn't even begin to cover the amount of data we're dealing with. The health data itself is heterogeneous. What I mean by heterogeneous means that it's a mixture of what we call tidy data or structured data, which often comes in tables, which follows standards, which follows codes, which follows particular formats like ICD-10 or Snomed, versus what we call unstructured data. Most of our health data that gets inputted into digital electronic health systems are unstructured. They are documents, they are pictures, they are scanned images, they are free text. They come in a variety of different formats. And some estimates are that 80% of the data that a hospital has to deal with is unstructured. So as a result, this heterogeneous data is what we would call untidy. It therefore is very difficult to interpret. And this health data is often scattered through our hospital. In our hospital, this is just an architecture map of some of our systems of a few years ago. We have more than 100 different databases and health record systems. This is largely because the systems were built over, accreted over time through evolution. Technical evolution, as departments bought new systems and plugged them in. And many of them ended up being legacy systems or sitting in silos in a non-interoperable format, and this data is fragmented. And this often results in having to re-input the data over and over again, and we end up in a scenario of death by 1,000 clicks, where clinicians end up inputting data repeatedly or in inconsistent formats. The scattering of data means that we have to take control of what we call the data lifecycle. Data is like Lego pieces, it's scattered everywhere in a house. There's a little bit on the floor, a little bit in the cupboard, a little bit in the closet, a little bit in the toy chest, everywhere. We have to pool them together into this big pile of pieces, and then we have to sort it, then we have to arrange it, and then we have to analyze the data. And that's when insight actually only happens at the bottom of that chain, and there's a huge amount of work in terms of the beginning bit. This process, data scientists call data wrangling or data sorting or data cleaning. This is often underestimated when considering the need for data technologies. So our thinking in our hospitals was to build a process, a life cycle, which manages this in a scalable manner. We pool the data first into data lakes so that it's all into one place. These huge data lakes need to be able to handle all kinds of data, from structured to unstructured. It has to be agnostic on the data types. It also has to be able to handle images. It has to handle things which come in all kinds of formats. Then once it's in one place, we need to standardize it. We try to derive meaning from it by using natural language processing, placing semantic terminologies like Snomed Ct. And we attach meaning to this structured data, and then we rationalize it. Only then can we begin to apply it. And these first 3 or 4 steps before we can even apply it is a huge amount of work, and it's often underestimated. So in this piece of work, we often, this diagram here shows the data life cycles that have to happen with all the source systems feeding data into pipelines and batch processing into a big lake, and then it has to be cataloged. So this entire process is extremely onerous and time consuming. And this is, again, a process which other industries have begun to solve. But in healthcare, we have only begun to. So what we've been doing is laking legacy data. What we use is a technology called CogStack, which combines a mixture of technologies, open source technologies, to ingest text and harmonize it and index it for searching. This technology then puts it into a massive data lake, which then we can process it with AI-based language processing. So language processing, which does the process of reading the data. When we first did this 5 years ago, we discovered that we had about 1.5 terabytes of data from the last 15 years, and that we have been accumulating about 0.1 terabytes every year. This is a huge volume of data for a hospital, and this means that we do not have enough human eyeballs, human lifetimes to even read the letters that we are and information that appears within our systems. So that's why we developed these AI-based technologies to surface the data and allow searching. So one of the first things that we did during the pandemic was we generated live text feeds of the hospital as clinicians inputted data about patients, about symptoms, about notings, dictations. Within our lake, we generated trending text feeds, which generated signals for how many patients were having what symptoms, what kind of suspected diagnosis were occurring, and we've published this in Nature Digital Medicine. And this information is essentially free once you build the architecture. Doctors don't need to input any special forms. They don't need to do anything different. And what we see is a trending within the electronic health record feed, very similar to seeing things happening in Twitter. And we used this during a pandemic to detect trends of COVID happening. We get upslopes in the amount of symptoms suggestive of COVID a few weeks even before we get an upsurge of a surge of COVID. So during the first and second waves, we've been monitoring this, and as well as in the third wave. So these are slides from the second wave when we were monitoring very closely the almost like a temperature gauge of how much activities of COVID-related activity was occurring within the hospital, and this was generated in real time. With these analytics, we can then perform differentials and more sophisticated algorithms to track trends and to prepare for lockdowns, as well as turning back on normal elective activity. So this kinds of real-time information is critical, and this is only possible by linking large amounts of data in an agnostic format. This data that we have progressed from there to using semantic natural language processing, which attempts to use AI to label the health data with machine-readable meaning. And in this context, we talk about Snomed Ct, which is an international standard of coding information relevant to clinicians and healthcare professionals. This technology has all been developed in the last 1.5 years, and we have open sourced it for hospitals around the world, and we are in the process of releasing the code and all this information to available to any hospital that wants deployments. It's all on GitHub for free. So what we've learned to understand is that to make AI and data-driven tools, we need to be able to clean, sort, and arrange data. But doing that in cold data sets, retrospective data sets is one thing. To actually use AI and these systems, we need to be able to do that continuously and rapidly. And that's the foundation of everything. We need data infrastructure and modern networks which can handling this information in bulk. And we need to attach meaning to it so that machine learning and AI can be developed from it and can then therefore use it. So any organizations which want to sort out their future, they need to sort out the infrastructure first, and the data infrastructure, rather than buying trendy AI or machine learning tools. We have worked we are also building architecture for scaling up AI, and this is something that we're building with the London Medical Imaging AI Center, in which we're building integration engines as well as federated learning platforms, which allow AI to be transmitted from hospital to the without moving of the data. This allows AI to learn from many different hospitals and to maximize the use of data while preserving privacy. This AI would then be pushed back into the hospital in a deployment engine, which will allow scalable use in real time. Again, all this requires data to be pooled, sorted, arranged, cleaned, standardized, all in real time with minimal human intervention. And so in summary, I think these are the kind of principles I would say that one would need in a 21st century hospital, that the quality of the data and the timeliness of the data outmatches the volume of data. Lots of hospitals accumulate large volumes of data in big data warehouses, but this data is often cold and is not cleaned. We need, for data to be useful, it has to be timely and it has to be of high quality and enriched. The technologies need to stream high quality data in real time, and this streaming data means that hospitals need to be able to handle the collecting, pooling, sorting and cleaning and enriching of data with minimal human dependent steps. We need to reduce the amount of human eyeballs needed to read the letters. Even the task of writing the letters by clinicians is hard enough, but the task of reading and interpreting and providing this information back has to be provided by machine technologies. And this is, I think, the future for transforming healthcare. That this is what's going to deliver agility and responsiveness, the timeliness and data enrichment, rather than necessarily the latest shiny product. Thank you very much. Any questions?
Thank you, Professor Teo. Now we'll go into the question and answer panel part of the presentation. So Professor Teo will stay with us. I'm going to introduce Dr. Shannon Sims, who is the Senior Vice President of Data Operations for Vizient. He will be joining us by video, and he will be our moderator for the question and answer session. And while he's getting up online, as you can see, this is the beginning of our big data special interest group that Vizient will be doing with IHF for the next couple years. There are representatives probably from a number of your institutions that are part of a steering committee to help us. As you can see from today's presentations, it's not the amount of data, and there's not an easy button. There's a lot of work to make this data usable and meaningful. So with that, I'm going to give the floor over to Shannon, and I'm going to go sit down at the table.
Thanks, David. Are you able to hear me okay there in Barcelona?
Yes, we can.
Wonderful. So, Dr. Levine, I'd like to start with you. You and I worked together, and we were recently on a call with a very prominent U.S. and international healthcare system, and one of their leaders said, I've got 100 analytics tools, but nobody's actually doing anything to improve. He was obviously exaggerating to make a point, but I think his idea was that data is great, but the real goal here is improvement. So how do you move from data to actual improvement?
No, that's a great question, and I really think it takes the leadership, the C-suite of a health institution, working and getting buy-in and understanding from his or her clinical staff to really figure out what are those priorities of what you're trying to change and improve on. And generally, you should have a general sense of. And I've seen places that have scorecards that have literally hundreds of metrics, and they're not a top performer. And then I see some that actually have some very pointed metrics in a much shorter form, and they wind up being a top performer. So I really think it's prioritizing the kind of, just because you have the data doesn't mean that it's going to be the meaningful data to drive change. I think it's the focus of priorities. Are you trying to work on inpatient mortality or safety or compliance with a bundle? What are the outcomes? And then I think the key is within that, get buy-in with your clinical team that you're picking the right measures that are going to drive change. And then some of the qualities of that data is that data that you can get on a fairly ongoing, regular basis, the appropriate cadence to drive change as you get that data to come back where it's not noise, and ideally where it is able not to only look at it at a high level, but to drill down to either the patient level or the physician level or the service level, that again, you can take that data, figure out where you have that opportunity, and then intervene to change.
Yeah, that's a great answer. And Dr. Sybil, building on that, so as we try to use that data to improve, I know the organization that you're part of is one of the largest, is the largest corporate hospital organization in India. You have hospitals in all kinds of settings, from dense urban markets to rural settings. You take care of all kinds of different kinds of people. So how do we take this data and AI tools, and how do you scale it across a large enterprise like that and across a very complex patient base?
Thank you, Shannon. So, we spread across the length and breadth of the country. We have 10,000 beds across 73 locations. So we actually had a model that's really come in very handy that we've been able to deploy when it comes to big data and AI. So we have what is known as Apollo Clinical Excellence, or ACE, and we developed this about 12 years ago. And this is a balanced clinical scorecard that looks at outcomes. And over the years, we've been able to refine it and go through 3 versions. So using that as the base, what we did was focused on 3 C's. The first is clarity. Why are we interested in AI and ML? I mean, what are we getting out of it? And once it is very clear to everyone that it's about putting the patient at the center and making sure that the data that we analyze and the algorithms that we develop and the programs that we develop are actually going to make a difference to the care that we deliver at the bedside. So that's clarity, because if it doesn't meet this parameter, then you're not going to get the enthusiasm from everyone. The second is collaboration. And collaboration just does not mean that you sit together once and develop a program, but it's really giving a seat on the table to everyone within the network. So the smallest hospitals also have the freedom to come up with suggestions, and this collaborative process looks at different stakeholders coming together, multidisciplinary teams coming in and brainstorming. So collaboration really in the true sense of the term. And the third is communication, because you can have clarity, you can have collaboration, but if the communication breaks down, then it's all going to be brought to naught. And thanks to the connectivity that we have and the fact that virtual is now a way of life, I think the connectivity has improved considerably without having the need to travel. And I think with active communication and communication that's very transparent, I think we have the third C that we'll be able to tick. And I think with the 3 Cs, we've been able to create a framework which we believe will serve us well as it has in the past as we move into AI and ML.
Yeah, that's a wonderful answer. Thank you. Dr. Teo, this is for you. And one of the things that I think about a lot as I think about data and informatics and AI, and your talk gave a really great summary of all the foundational work that has to happen in order to get things ready for clinicians and for our patients to use. One of the challenges that I've encountered in my career thus far is building trust in the use of technology-driven interventions or the use of AI. And so the question I'll pose to you is, once you've done all that foundational cleaning and getting timely data, how do you then get or nurses or other types of providers to actually use and trust the tools?
Well, thanks, Shannon. Well, trust is really dependent on being able to see the data transparently, as well as the inference or analytical process that was used to make the decision or suggestion. So where we're moving from is where we really need our white box approaches as opposed to black box approaches at this stage. So for population level work, we need simple KPIs, simple outcome metrics, things which are very easy for clinicians and healthcare professionals to understand. Next is that we need to develop AI systems and data systems that know when they don't know. Systems need to show the degree of uncertainty and capture that, and to be able to produce error logs or just to say, I don't know. Use your human judgment. And these simple measures, I think, is a key foundation, stepping stone towards more complex AI. Keeping this will keep humans in loop, and it would be premature to automate most clinical activity as a result. Nonetheless, beyond this white box space, there will be some limits that we can achieve with such an approach. Future analytical techniques are what we will call very high dimensional, very difficult to comprehend, and it requires quite complex mathematical minds to appreciate. And at this stage, we reach the different stages of grief, as David's talk, in which we will start encountering a situation around data literacy, organizational culture, and improvement in change management at that stage. And that's a kind of something down the road. But I think there are plenty of things we can achieve right now with a white box approach.
Yeah, thank you very much for that. You've used a couple of phrases that I'm going to immediately incorporate into my personal vocabulary, which is unstructured data is untidy and white box as opposed to black box. This is a question for the panel. One of the things that I worry a lot about is that AI has the potential for good, but it also, like any intervention, has the potential for harm. So are we inadvertently introducing bias or worsening disparities between different populations of patients? So Dr. Sippel, I'll pick on you. How do we make sure that these technology and AI approaches don't worsen disparities of care?
I think you make a very valid point, Shannon, in terms of being very careful, whether it is the regulatory framework, it's ethics, it's about getting all the stakeholders to actually have a voice, it's about looking at pilots, making sure that the tools that we come up with cover all ethnic groups, they cover all the social and the economic substrata that every society has. And if we do this right, I believe technology can be a great leveler. And I'm just going to throw some data points because this is about data. And I live in India, so we have only 1.34 billion people. And I'm just going to share with you what Digital India is all about. So we have 1.5 billion phones, 770 million smartphones. 65% of India lives in 600,000 villages. So a farmer today can decide based on the prediction that is given out on what seeds to sow and what will be the support price for the produce. Through smartphones, we are able to transfer subsidies directly into bank accounts for which people had to run around and spend a lot of time. We recently launched a digital health mission where all 1.34 billion people will have a digital health record. We already have a digital ID that's based on an iris scan for everyone. So it's going to be built into that. And through that, we're going to be able to deliver care at the doorstep like we couldn't have earlier. Just two classical examples. Tuberculosis. Through AI, you can actually diagnose tuberculosis based on a radiograph, you don't really need a radiologist. We've already started using technology in terms of thrombolysis for someone who has a stroke based on a WhatsApp-driven algorithm using AI. So I think the benefits that are going to accrue are going to be huge. We've seen that with vaccinations. We've now administered 1.1 billion vaccines. And we're really proud of the fact that all the vaccines were made in India and everything is digital. So clearly, I think using big data, harnessing the power of data can be brought to good use. But of course, we have to be careful that we make sure that we don't digress from what would be expected as good ethical practice.
Yeah. Dr. Teo, would you add anything to that?
Well, I completely agree with Professor Sibel's point in terms of access. I think the other issue I think I have personal views on is around the conversation about bias. Sometimes occasionally gets misconstrued that any differences detected by AI in the data is a bias. So differences in data does not necessarily mean it's unfair. Differences, AI is very good at detecting differences in data, but often these differences are either necessary differences or differences which are worth detecting so that we can correct for the bias. So bias, therefore, is a result of poor use of data. Is either underrepresentation of groups or populations as a result of missing data, or use of protected characteristics like age, sexuality, ethnicity, which do not fit with the societal expectations of the use of that data. We accept that pediatric patients are very different from elderly patients, whereas some other characteristics a particular society may not feel that it's appropriate to collect that element of that data. So the first issue around underrepresentation is around curated registries and data sets. So a lot of AI that's produced nowadays are generated from very pure data sets, which are very clean, often in first world countries, generated because they can collect such clean data sets. But as a result, they tend to filter out the underrepresented populations. And so real world comprehensive data capture is the best way to combat this bias, by making sure that all the data is captured so that all groups are properly represented. And the second case is a more complex one, is around the societal decision about what kinds of traits should we be capturing in that data, and what traits should we be allowing AI or data analytics to perceive the differences in. And this is a much more complex cultural decision, and I think it's very, very locally dependent. And I think the last scenario is misuse of AI, which is unbiased but used outside of context. So using, for example, a chest X-ray design for tuberculosis detection in a completely different scenario, in a different population. And that sort of scenario means that we do have to think of these AI products or software as medical devices with clear boundaries around use, and that the clinicians and staff who use it need to understand the contexts in which they are produced, and when they can be used and when they can't. And so basically, systems which know when they don't know is going to be key.
I like that. Yeah, so if I could summarize what I heard, is we have to ensure that everyone has equitable access, that we have representative data sets to build models, and that models are thoughtfully created with some built-in safety nets to ensure that they do their job in the best way possible. Dr. Levine, for you, this is an international event. It's the World Hospital Congress. We've got representation of commercial entities like Vizient, where we work, a commercial entity like Dr. Sibel, and of course NHS. But so how do organizations, private companies, healthcare vendors like ourselves, and providers, as well as public entities, collaborate to make best use of data and to drive forward improvement in care?
Yeah, great question. I think, as I've spent my time here and I've learned more about internationally, we're more same than different in the problems that we're all trying to solve. But so far with big data, we've still been generally focused on our own countries, and actually really looking at the variety of how healthcare is delivered, and actually utilizing the data for more real-world evidence of what's effective and what's not effective versus, and I think it was Dr. Sibel who had rightly so, showed that, how long it takes to debunk, a medical myth and versus how long it takes to like a new technology. I think there's a real opportunity, and actually we saw this around COVID, how the world came together to really fairly quickly learn what therapeutics, and which how to ventilate patients, was the most effective, fairly early in COVID, and both to debunk myths of certain pharmaceuticals that were not effective, but to advance other solutions that did work. I think more and more around chronic disease management is an opportunity using this data for real-world evidence with the variety of how we deal with that. I think there's a huge opportunity, and this came up again with COVID, around really determining the impact, not only the impact of social determinants of health, which we know, but how do we change and how do we get more personalized, with the knowledge that we have, the right treatment to the right patient and the right other resources around, and treatment being broad, not only what we do in the hospital or in the clinic, but connecting them back to community resources and whatnot, I think is an opportunity for all of us to come together internationally to come up with the best solutions.
Sounds good. David, I'm getting a message that unfortunately it's time for us to wrap up, so I will hand it back over to you, and it was very nice to speak with you all.
Great, thank you so much. Thank you, Shannon, for that great question and answer session. Just a few reminders before we go. Please share your key takeaways from the session and post it on the Congress app and on social media. The recording of this session will be available on the event platform in a few hours. Next up is the Ihf Awards Ceremony, which is happening at 6 o'clock Barcelona time. We hope you can join us there. I believe it's in the auditorium for those of you that are here live, which is like right next door, to celebrate the outstanding initiatives of hospitals and healthcare organizations around the globe. Tomorrow, the plenary session will start at 8:30 and is focused on humanizing digital technology. And finally, don't miss the closing plenary session tomorrow, where the Minister of Health of Catalonia and the Director General of the Dubai Health Authority will share key features of their hospitals and healthcare delivery systems and discuss the importance of international collaboration. With that, thank you to the IHF for helping us host this session, and look forward to working with all of you moving forward.